This program is intended for informational purposes only and does not contain medical advice. As always, please contact your physician or qualified healthcare provider with any questions regarding a medical condition.
And I'll never forget, I was laying on the table for my C-section and I looked and the blood was just spilling over. It looked like a faucet. Now, I've been in this field for 17 years and I was like, it's go time. I am a statistic of maternal morbidity. I was mass transfusion protocol. Like it didn't escape me. And it doesn't matter if you have a PhD. The situation in this country for maternal health, it's crummy.
When we talk about Black maternal health, why are Black women in the US still dying and suffering complications at an alarming rate, 3 times that of any of their, ethnic or racial counterparts? What's up, everybody? Welcome to another episode of Hot and Bothered with Melyssa Ford. I am sitting next to Monica Carter, who is an award-winning Maryland native family nurse practitioner working in obstetrics and gynecology, serving the DC, Maryland, and Northern Virginia area for the past 17 years. Hi, Monica!
Hi, Melyssa! Eminem.
As you could, exactly. As you could probably tell, we have been very giddy about this, about doing this episode. We were introduced by a mutual friend. What's up, Duck? And he just thought that you were going to be perfect because when he and I met, somehow, some way, I am able to enroll people into a conversation about menopause.
I love it.
Within 5 minutes of meeting me, I start talking about menopause and I just enroll whoever's in the area to start talking about it with me. And he was like, you have got to meet my friend, Monica Carter. Mm-hmm. He put us together and we gabbed on the phone for the first time. It must have been like 2.5 hours. So it's like, we're like kindred spirits, we're here with each other. But let's start with your personal story, because your personal story is really fantastic, scary. It could literally be like a Lifetime movie from what you've told me. You survived having triplets. And we say the word survived because you had preeclampsia, DIC, and had to receive over 20 blood transfusions. First, in layman's terms, what is preeclampsia and DIC, and why are they so dangerous for moms and babies?
Absolutely. So preeclampsia is a condition that is hallmarked by high blood pressures in pregnancy, but these high blood pressures are scary because they start to cause organ damage, usually the liver and the kidneys. Preeclampsia, you can have right upper quadrant pain where your belly starts to hurt, visual changes, swelling, your blood pressure is going up, 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 you're spilling protein into your urine. You start to just feel like you're not yourself. A lot of women start to have like edema or swelling on their belly, just really swollen. And you're like, gosh, I'm really holding on to fluid, like gaining 5 pounds in a week, 7 pounds in a week. And you're like, this does not feel like baby fat. This feels like something else is going on. So preeclampsia is scary because obviously it can lead to eclampsia, which is seizures in pregnancy, which can lead to death or fetal demise. And then DIC is even scarier. That's a medical emergency that a lot of people don't actually survive. And that's why it's so special that I survived it. And it's when your body experiences some type of trauma, usually trauma or infection or something really traumatic happens to the body. And your body's like, oh, okay, I need to make some clotting factors. So it makes all these little clots all around your body. And then what happens is you're bleeding out and you actually need those clotting factors, but you've used them all up before. So you're bleeding out and you don't have the clotting factors to make your body stop bleeding. And so you bleed out. So when I had my triplets, I ended up losing 7.5 liters of blood. Now, the human body only has 5.5 liters of blood. So I lost my entire blood volume and about half of some other great blood donor in DC, someone else's blood volume too. So I lost 7.5 liters, and I'm just so thankful to be here. I talk about this story because it didn't just start as I had this traumatic birth. I didn't have just this maternal morbidity. I didn't just have this traumatic birth that just started that way. It started with the good news that I was pregnant. And then it started with the shocking news that I was pregnant with triplets. And that became me being on an assignment. I knew this was going to take a huge undertaking to get these 3 kids here. This was completely natural, no IVF, no medications, no family history. This was just like, here's 3 kids. And honestly, there was a part of me that was kind of embarrassed because I had friends that were struggling with fertility issues. And I'm like, here I am with 3 kids up in here. I can't tell nobody about this. It's like, this is too much.
Wow, that's an interesting perspective to feel like you had to keep the secret for other people's comfort level.
I did. And I think that's just
compassion.
It's me as a healthcare
empathy.
provider and just who I am. But I was on an assignment, and I finally announced on social media around 7-ish months that I was pregnant with triplets, and I had my daughters at 32 weeks. I knew that I was in big trouble when I went to get some blood work, and my kidney function was in the toilet. Like, I'm talking kidney failure. And they were like, it's dialysis or we have these kids. And just FYI, you need to have these kids. My husband was in Jersey, actually, being the best man in his best friend's wedding. He had to rush on back because we had the kids the next day. So he was partying, having his last dance. But they rolled me back for the C-section. Baby A came out, just like a little runt, 3 pounds, just so perfect and cute. And Team A took her to the NICU, which is the neonatal intensive care unit. Then baby B was born 2 minutes later, Team B. And this is a big birthday party. You know, we have 3 teams for these 3 kids, plus I have my own huge team in the operating room. And Team B takes baby B, another little 3-pound runt. And then Team C takes baby C. And all 3 of them come out crying, and it's wonderful. And I'll never forget, I was laying on the table for my C-section, and I looked, and the blood was just spilling over. It looked like a faucet. Now, I've been in this field for 17 years, and I was like, it's go time. We're about to, like, it's about to go down. Now, there's a part of me it's kind of sick, because I was excited, because I'm like, the medical professional in me, I'm like, I know, we about to get it in.
I know exactly what you mean.
It's about to, like, they're about to be calling everyone's about to show up, another anesthesiologist, another surgeon, the blood bank, like, it's going down. And the anesthesiologist who was with me, he was like, do you want to be awake for this? And this is a friend of mine. And I was like, put me out. And I looked to my right, and I saw the white stuff coming towards me, and I went to sleep. And I woke up, and obviously I was in recovery. But it was a huge undertaking to get the kids here. I was very, very sick. And had it not been for my advocacy, had it not been for the team that I chose, had it not been for the hospital I delivered at that has a fully functioning blood bank, like a world-class neonatal intensive care unit, I definitely wouldn't be here today. I heard that the hospital that was down the street from the one I delivered at, they actually ran out of platelets that week.
Wow. Because of you?
No, because of whoever. But just to say, had I been there needing platelets, I would be dead. I wouldn't be here.
Yeah.
So everything aligned perfectly for me to be here today. But preeclampsia is scary, DIC is scary. When we're talking maternal health, maternal morbidity, maternal mortality, some of those, the heavy hitters are high blood pressure, so preeclampsia, hemorrhage, so that bleeding out, right? Cardiomyopathy, when your heart is working too hard and it gets enlarged. These are things that happen, and understanding them early and being able to prepare for them is life-saving.
I don't think that people really take into consideration the catastrophic event that having a baby is. People just really kind of romanticize the idea of having a baby. Like, I'm gonna have a baby. And you don't really process just how much your organs being moved around, how you can end up with heart trouble as a result, like you described, all of the serious conditions that can develop during the course of pregnancy. It sounds like you went through hell and back for these angels.
There was a night I was pregnant and I couldn't sleep. And
how far into the pregnancy are you here?
Gosh, I was maybe like 25, like maybe 6-ish months.
Okay.
And I remember someone was like, oh, when you can't sleep, listen for God's voice. And it's not like I'd never prayed before. I'd never listened for God's voice, nothing like that. But just for some reason, it was really like in my head that night. And so I did. And I'll never forget, I heard, you're going to need 3 lines. I put it in my little notes and I fell asleep. About a month later, same thing, couldn't sleep. Really was something was stirring in me, like, what is this? Did it again. Like, let me listen. At this point, we besties. Like, you talking to me, I'm talking to you. We got this relationship and everything. What you want to say? And I heard, do not leave labor and delivery under any circumstance. So I rushed to my high-risk doctor, which is a maternal fetal medicine specialist. So anyone with a high-risk pregnancy out there, make sure that you get a maternal fetal medicine specialist because they are specifically trained in high-risk pregnancies, which is it's a medicine that's a little bit more sophisticated than just general, obstetrics.
Yeah, no,
right?
that was actually going to be my next question. What are some of the critical moments where maternal outcomes like yours can be tragic, or what saves you in these moments? And you just said critical.
Yeah, a maternal fetal medicine specialist. So that's a high-risk doctor. So we're right here because I went to my general obstetrician and I said, listen, I know this is going to sound crazy, but I just need you to listen to me. I was told I'm going to need 3 lines. And what I took it to mean was 3 IV sites, IV lines. So you get like an IV in your arm or your neck or wherever so that they can get fluids and blood and things like that into you. And this is for any surgery or any delivery, et cetera. And so I was like, I need 3. Now, normally for a pregnancy, you have 1 or maybe 2 if you're being conservative, but 3 is just like crazy. You don't need 3. But I was like, I need 3. And I was like, and I don't want to leave labor and delivery no matter how critical I am. I don't want to go to the ICU, the intensive care unit. And my doctor was like, gotcha. She listened. And I told her, I said, I just need for you to trust me when I say things while I'm pregnant. This is part of me getting these kids here safely. She was like, done. So the MFM, we told the MFM, we told the anesthesiologist, we told everyone, this is the plan. Everyone has this birth plan where they're like, okay, I want candles, and I want to be able to be skin to skin, and I want my makeup done, and I want pictures in the first 24 hours. Oh, and I want daddy to cut the cord. And I'm just like, I want to live. I need to live. And so I told her these things, and we get to labor and delivery, and they give me my 1 IV, and I'm like, I need 3. They're like, Monica. I was like, I need 3. So they gave me another one, and then they had the IV access team come and put a nice big fat juicy one in my neck. Big juicy one in my neck. And then I went to the OR, and I sat up for my epidural, and the first one blew, which means it no longer worked.
Oh, wow.
So now I had 2. I laid down for my C-section. The second one blew. 26 blood transfusions went in that last IV. I would not be here. Again, because they listened to me and trusted me, because I advocated for myself, and I was like, I need 3. And I'm a healthcare professional.
Yeah.
And these are my colleagues. Like, they know me. We're friends.
This is a different level of advocacy for yourself, though, because of your experience in the field of which you practice, and also because you were surrounded not just by, colleagues, friends. You avoided what the average woman, has no idea what to ask for, how to advocate for self. Like, this is a very rare experience that you're describing.
It is. And I share the story because preeclampsia and having triplets, those are not the only high-risk issues. Women have high-risk issues every day. They have diabetes, they have high blood pressure, they have a history of multiple surgeries, they have a history of myomectomy where the fibroids are taken out, other abdominal surgeries, a history of recurrent pregnancy loss, IVF. There's a laundry list of conditions that predispose you to have a high-risk pregnancy. And those could be conditions that could have you needing to advocate for yourself. So the long story short, we know how the OR went, the blood. I went back to my room, and they were like, we really want to get you to the ICU. And my doctors were like, she stays here. The ICU doctors, they can round on her down here. The residents, the medical students, they can all come and visit her here, but she stays here. This is a part of the plan. And when I say those nurses stayed at my bedside day in and day out. And labor and delivery nurses are very intelligent, and they're very capable. And they were very capable of keeping me alive, and they did. And some of the issues I had 24 hours after I had the babies were issues that only a labor and delivery nurse or physician would catch. And they did. And they were able, I had a Bakri balloon, which is something that they put in my uterus to keep it nice and tight so that I don't bleed. It needed some adjusting. It would never have gotten caught on ICU, but they caught on the L&D. From there, I started improving. I started getting better. And I'm here. I'm here today. So it's like, yes, I have an unfair advantage. I work in obstetrics and gynecology. These are my friends. I'm like, listen, I want to live. I don't want to die. But also, I had over 20 blood transfusions. am a statistic
It's
of maternal morbidity. I was
yeah.
mass transfusion protocol. Like it didn't escape me. And it doesn't matter if you have a PhD. The situation in this country for maternal health, it's crummy.
It's more than crummy,
I
want to dive into that because you mentioned in your story maternal morbidity but not mortality. What's the difference, and why is it important to talk about both?
It's important to talk about both because morbidity is basically I'm here still to talk about it, but shit went down. It got bad. So morbidity can be how many blood transfusions you got, if you had to get another surgery, if you ended up needing a hysterectomy after your delivery, if you ended up going to the ICU, you were intubate. Morbidity means harm was done. And it's not of someone's fault, but it was a traumatic birth. And mortality is you didn't make it. You die.
Yeah.
And there are medical emergencies where that happens. And unfortunately, I've seen it.
When we talk about Black maternal health, why are Black women in the U.S. still dying, and suffering complications at an alarming rate, 3 times that of any of their, ethnic or racial counterparts?
It's multifactorial. The glaring obvious number one is medical racism. I'm just going to put it out there.
It's
the glaring one. Unfortunately, there has been a sordid history of bias in this country where not only do we believe that Black women can handle more pain or don't experience pain the same, we are not seeing, if our kidney function is not as great, it's like, okay, but it's not that bad. When our blood pressure is high, it's like, well, it's not that high. Whereas
I don't understand when they say that high. What's the baseline?
The baseline is this. If it's 140/80, 2 blood pressures apart, we're talking gestational hypertension. We're talking you have high blood pressure in pregnancy. We need to start monitoring it. That means you need a maternal fetal medicine specialist to do extra surveillance on your baby, to do more ultrasounds. That means that we might be doing urinalysis to see if you have protein in your urine. We're going to do more blood work. It's just an increased awareness, increased surveillance, and a potential earlier delivery date. And no one wants to hear this. They don't want to hear it.
I've always wondered why. Why is that such a big thing? In movies, television shows, and just even from friends, when they hear that they've got to deliver early, they have this look of terror on their face, and I don't understand why.
Yeah. There's early that's scary. Like when I delivered my daughters, they were 32 weeks. So that's 8 weeks early. Thankfully, they did beautifully, and they're perfect. They really are. But again, we have one of the best NICUs in the country at the hospital I delivered at. So again, very fortunate to have world-class medical care for my kids. So there's early that's scary, but 37 weeks is technically term. And after that, your baby should do really well. Even 36 weeks is a late preterm. I think what happens is there is a glamorized, like you said earlier, there's this view of how birth should be. And it should just be this really beautiful, amazing experience with not a hair out of place. Baby comes out, someone's looking at you lovingly. The baby, and that's just not how it always is. No. It's usually actually really messy. It's actually usually really messy. I think that patients are worried, or women are worried that something will happen to their baby. Something's gonna be wrong with their baby. And they also have a hard time divorcing themselves for the birth that they saw, the natural birth or the vaginal delivery or whatever the case. To me, healthy mom, healthy baby. There's 2 ways to get the baby here.
Yeah, I agree with that.
So I would say that, and going back, you said, you asked why the I guess, issue with wanting to deliver early. I think it's what we think ourselves, but I also think there is a general distrust of the medical community.
Yeah. I can understand that. I was going to ask, what do you feel like are the biggest gaps in maternal care across hospitals and clinics today?
I think the biggest gaps, number one, standardizing care. I'm serving on a board in Washington, D.C. right now where we're standardizing care across Washington, D.C. And I love standardized care because that means that the Black woman and the white woman and the Latina woman and the Asian woman, everyone, when we see this blood pressure, we do this. When we see this lab result, we do this. They're algorithms. And it helps to take the bias out of healthcare. So I think standardization across the country could help. I think that there's different levels of evidence-based practice. When you're around these amazing medical centers in some of these big cities, you have this world-class care. And then unfortunately, you have some places in the country where you're going hours and hours to get to a medical center like that. The care might be a bit outdated and they might not be up to date with what we're doing now to save women and help women. And then of course, medical racism. Seeing someone, and I'll never forget this, I did this whole workshop on how to decrease your own bias. And the first question that you ask yourself is, what would I do for this patient if everything they're saying is true? If the pain they say they have is true, if the bleeding they say they have is true, if the hot flashes they say they have, how would I treat them? Because the problem is, first, not being believed. Some women they go in, they tell their doctor everything, they tell their healthcare provider, and no one believes them.
Why? Where does that come from? Where does that idea of, that skepticism develop within, doctors and even nurses, even though it's usually, told, when you hear the stories, it's usually doctors that are on the end of, not being, the ones that are not believing you.
Yeah. I think obviously implicit bias. People have some deep-seated things that I will never quite understand because I just love folk. Like, I really do. And it sounds corny, but I love my patients. It doesn't matter what you look like, how old you are, what you've been through. I love my girls. And I give everyone the care that I would want to give my mom, my grandmother, my sister, my best friend, my sorority sister. That's the care I give to everyone. And that's how I check myself. That's how I make sure I'm giving world-class, comprehensive, unbiased, patient-centered care every single time. And that's why the patients continue to come back to me, because they know I'm listening to them and I care. You can't teach people to be human. And the truth of the matter is, some people, they just don't have it. They're doctors, they're brilliant, amazing surgeons, but they don't have that humanity. And I think that comes from history of going through some things. And if you've never been through anything, I just don't know that you can really truly relate to women.
Yeah, there's a I don't know if it's a statistic or it's something that's just making its way around the internet and whatever else, but the best care is most oftentimes received by Black female health practitioners, whether they're nurses or doctors. And that's probably based on the experiences that they've had themselves of being ignored, being gaslit, being dismissed, and just all in all, garden variety trauma that we experience on a, daily basis.
Agree.
Yeah.
I mean, we're lit. We're lit. What can I say? There's just really no duplicating it.
Okay, so first, let's talk about what your day-to-day looks like, because I know that a large part of your practice is dealing with menopausal patients, which I'm so excited talking about that. But let's talk about what your day-to-day looks like, and then we're going to get into, perimenopause, postmenopause, treatments, et cetera, et cetera.
Every day I'm seeing a mix of gynecologic and obstetric patients. So I'm seeing patients for their breast pain, their period pain, heavy periods, irregular periods, PCOS, fibroids, menopause issues. I'm also seeing just your annual, which is just like your checkup where you get your pap smear and your breast exam and you get all of your screening. So I order your colonoscopy, your mammogram, your bone scan, et cetera. I'm seeing patients throughout the lifespan. I'm seeing pregnant patients throughout their pregnancy. I don't do any of the deliveries, but I get to see them in the office, which I love because I prep them. And I always say, I am like the coach or if you think about a coach that preps a boxer, you are fighting in the ring all the time. And then on the big day, all you need is someone to squirt water in your mouth and dab your head and put a little Vaseline on your face. That's your spouse or that's your partner. But what I do is I do the background work as a coach and I get you ready. So although I'm not there delivering the baby, I make sure that you and your partner or whoever's gonna be there to support you are ready for that. So yeah, my day-to-day, it's diverse, but it's always seeing women. And that's truly my ministry.
So let's move on to cervical cancers, pap smears, and HPV, which is something that you also handle. The recent loss of influencer Jessica Pettaway at 36 was a shock to so many people. What does her death reveal about gaps in cervical cancer screening and awareness?
Yeah.
36.
It's really sad.
It's so sad.
It's really
she was
sad.
so young.
It's really sad.
And then later on in the episode, we're going to obviously talk about Ananda Lewis, who we also lost too young, 52 years old, to breast cancer. So we'll discuss that a little bit later, but let's talk about Jessica and cervical cancer screenings, awareness, and all the things that we don't know and that we should.
It's really sad. I think that one thing I've noticed is I don't know that people always understand what the pap smear is and if they've actually gotten a pap smear. And let me tell you why. I have so many patients who are like, oh, Miss Monica, I was in the ER with the UTI and they did a pap smear. They didn't do no pap smear. They didn't do a pap smear. A pap smear is a cervical cancer screening, and it's never done in the ER. It's never done in urgent care. So if they do a vaginal exam, if they put a speculum in that looks like a duck beak, it goes in the vagina, opens the vagina up so they can see the cervix. If they do something in there, it's not a pap smear. They could be doing STI testing. They can be looking for yeast, bacterial vaginosis, mycoplasma, ureaplasma, whatever. But they're not screening for cervical cancer. That's only done with your PCP, your primary care provider, or your GYN. So the first issue, I think, is I remember with her story, because listen, this story wrecked me. Like, I was so sad about it. And I think that a lot of us who are in gynecology were sad about it. I believe she was having a lot of issues. My understanding is she went to the ER. They did an ultrasound, saw some masses in the uterus, pegged them for fibroids, which is not a bad guess, but
they should have done a little bit more investigation, maybe possibly ultrasounds or biopsies or.
So they did. So they did the ultrasound. They saw the masses. They were thinking fibroids. And then I guess she was having issues after that. And then I think she ended up getting a biopsy and realizing it was invasive cervical cancer. So a few things that stick out to me. And it's sad because it's, retrospect's always, hindsight's 20/20. Number one, we should be going to get our pap smears from the gynecologist and PCP. No woman should have cervical cancer in 2025. Wow. No woman should die from cervical cancer in 2025. It should not happen. Because with proper screening, we have so many steps that we can take to make sure it never invades the cervix. And that's and that's the one thing I love. I mean, I love that we have almost completely eradicated cervical cancer through the Gardasil, which is a vaccine for HPV, because HPV is the virus that causes most cervical cancers. And then just through screening. So if you're getting your pap smears regularly and your doctor says, your pap smear is abnormal, you need a colposcopy which is a biopsy. What I see a lot of times is my patients are too scared to come back. They're terrified, so they don't come back. And years go by, and they come and see me, and they want their pap, and we do their pap. Again, it's abnormal. I say, you really need to do a colposcopy. I push it, I stress it. They're scared.
What is a colposcopy? What is it? It's
a biopsy.
So basically, they just lay you down on the table, speculum, and then they just take a scraping kind of thing.
Right. So the pap smear, they lay you down. They put the speculum in the vagina, open up the vagina, and they do a little scratch. That's the pap smear, right? Yeah. I mean, I can't speak for everyone, but my pap smears are very gentle. Very gentle.
That's why you have
very
over 500 5-star reviews, girl.
Very gentle.
I checked your Yelp. Ow, ow.
So they scrape it. And if it's abnormal, the colposcopy, a little bit more involved. But again, I'm talking minutes. This is minutes out of your life that could save your life. Again, they put the speculum in, they open it up, and they take a little pinch. You do feel it. Ouch. And they send it to the pathologist to see, could there be cervical cancer, precancer, what's in there? And if it's normal, they might say, we'll see you in a year. If it's abnormal, they'll talk to you about your options. But if that colposcopy is showing dysplasia, which is abnormalities that are close to cervical cancer, they can freeze or burn all those cells off, and you start new, and you start fresh with a new, perfect cervix with no issues. So literally, you can prevent cervical cancer by just following up.
Yeah.
And unfortunately, what I think happens in these cases when we hear of someone with invasive cervical cancer is the ball was dropped somewhere. Either wasn't getting screened properly, didn't get the colposcopy like they were supposed to, didn't have someone who actually educated them about what the next steps were. Maybe they didn't want to see the gynecologist, oncologist. You never know what it is, but unfortunately, there was a serious Swiss cheese effect with Jessica where
she kept falling through cracks.
Yeah. And that's why I say, unfortunately, especially these days with everything coming down the pike, we cannot wait for healthcare providers to tell us what we need. It is so important. In this digital age where you have YouTube and TikTok and Instagram and ChatGPT and everything,
we have no excuse.
It's so important to find out, what do I need as an X-year-old woman? What does that look like? And let me go get it.
Women don't know shit about their bodies.
Oh,
they don't know anything about their bodies. Like that, everybody, all that is on, social media right now is talking about the luteal phase and like all the phases that we go through when it comes to like our menstrual cycle. So everybody's caught on to this. Even men are just like, oh, just avoid her when she's in the luteal phase.
And they're like, wait, the ovulatory phase, like, get my shape up.
Exactly.
So I'm looking at her like, hey, boo.
Exactly. It's hysterical, but it's just like prior to this has maybe been about 3 or 4 months. Before this, nobody knew, women included, like all the phases that we go through in a menstrual cycle. It's crazy. Like, I remember the first time that I took a mirror and did this. I was like, holy shit, what the fuck is that?
Wait, why do I have mirrors in all my rooms?
Yeah.
And I get my mirror out, especially for my patients for their first PAP.
Yeah.
And I'm like, okay, put your head up a little bit. And they're like, whoa. I'm like, okay, this is your vagina.
Yeah.
I'm like, this is the urethra. This is where the urine comes out. This is the vaginal open. This, and I explained, this is the labia. This is how you talk about it. This is the vulva. This.
Listen, I've had a conversation with guys or just people in general. I was like, you know, we have 3 holes, right? They're like, no, you don't. And I was like, we do. And yeah, so it's interesting that you did not know that, but you're always down there trying to, you know, figure things out for yourself. But yes, we have 3 holes. People just didn't know that they had 3 holes, like as women, actually.
Oh,
yeah,
absolutely.
And so pap smears.
Yeah, I mean, I would say if I could say anything would just be ask your healthcare provider, did you get a pap smear? Am I getting a pap smear today? I want a pap smear today. Because just because they put a speculum in the vagina, it doesn't mean that you're getting a pap smear. That's a screening for cervical cancer. And depending on your last pap smear's results, you may or may not need one that day. But you need to ask, because I think the issue is everyone thinks every time something goes in the vagina, it's a pap smear. Mm-hmm. And then they go 5, 6, 7, 8 years and they have had a pap smear.
Mm-hmm. And by way, and we should be getting regular pap smears. That means annually.
So right now, the insurance company will continue to cover your pap smear annually as of this minute. Now, I don't know what's going to happen when the BBB goes into effect, but for now, you are still getting covered. So if you want it annually, you can get it annually. The truth of the matter is, the way the cells of the cervix are, they change so slowly, you actually don't need it yearly. If it's normal this year and you've always had normal pap smears, outside of having a new partner and getting a new HPV infection, it's going to be the same next year. So you can actually have some intervals, you know, anywhere between 3 and 5 years, depending on your age, depending on your pap smear history. But for all intents and purposes, I want everyone this year to get a pap smear, no matter where you are with your screening, because that way we're all starting fresh.
Okay. Let's switch gears and talk about breast cancer awareness and risk. So Ananda Lewis passed away this year. She went public with her breast cancer diagnosis several years ago, and her choice to forgo conventional treatments and treat it holistically. She passed away at the age of 52, and I've read statements made by some of her friends, and one of them said, you know, we loved her so much, but boy, was she hard-headed.
Yeah.
And I feel like that was an indication of the fact that even her friends wanted her to, in tandem with holistic treatment,
I love that.
perhaps also do conventional, because she left behind a world that loved her, but also she left behind a small child. And 52 just seems, it's too young to have passed away from breast cancer.
It is.
What were your thoughts when you heard that she had passed away, and also the choices that she made and the regrets that she seemed to express towards the end? I know it seems like armchair quarterbacking, you know, after the fact, but
it's a great question.
But I think that this is a conversation that has to be had.
I agree.
Because there's going to be people that think, oh yeah, let me just grind up some, you know, peach seeds in a, you know, in a macchiato grinder or something like that, and you know, and put that in my applesauce, and that's all I need.
Yeah.
No,
it is not.
You know, conventional medicine has been developed to treat specifically breast cancer in this, you know, in this circumstance, and it has proven to be effective.
Absolutely.
You know,
again, this is another one where I was really heartbroken, and I think you and
Everybody
I texted about it a little
Yeah.
bit. You know, because I have patients like this, and I think I have a really intimate look into what it looks like when patients make decisions for their health, when women, men make decisions for their health, what they want to do for themselves, they truly believe deep down, this is the best decision for them. Mm-hmm. And I think there's a lot of different factors. It can be cultural, it can be religious, it can be, you know, what you've heard. It can be misinformation.
It can be vanity.
It can be vanity. There's just so many aspects. And for me, what's heartbreaking is I see cancers that are so treatable. Mm-hmm. And yeah, the treatment option kind of sucks, but then it's over and you're cancer free and you get to live your life and you get to be of service in a new way because you're a person who's gone through something that really millions of people will go through at some point in their lifetime. And you can be a vessel for them, but by deciding not to do treatment that has been proven to work, mm-hmm. unfortunately, in this case, you're choosing that you could potentially not live. Now, I will say, I think a lot of this comes from, and I said it before, the mistrust for the medical community. Unfortunately, this country does not have a great track record with how we treat people. And
Especially Black people, especially Black women.
Black people, especially Black women.
Understood.
So again, we have a sordid history with medical malpractice, misuse of technologies and
experimentation
medications.
on our bodies.
I was going there. So I think that unfortunately the fear is there. And then also, there's a lot of side effects from certain options. But the reality of it is this. For me as a medical provider, I love complementary medicine. I love all the juices and berries and tinctures and potions and everything else. From every plant medicine you can think of, I love it. But I love it in conjunction with treatments that have been proven to work, that are tailored specifically for your cancer by your oncologist so that you can live your best life ever.
Yeah, one of the things that seemed to come up when she was talking about the diagnosis was the fact that she had avoided getting mammograms. And when she was diagnosed, which I believe was at the age of 47, she had never had a mammogram before. And by that time, it had, she had been diagnosed with, I believe it was stage 2. And the solution that was presented to her was a mastectomy, which I can understand is earth-shattering, I mean, a lot of what we believe makes us a woman is our breasts and our reproductive organs, which is why whenever women are confronted with the idea of having a hysterectomy, they also go through a similar, sense of, dissonance, But with mammograms, I've been getting mammograms since I was 40. I'm on my screenings.
Come on.
On them.
And I love that.
And
I love that.
Thank you.
And that's how it should be.
Her fear was radiation, but I'm just like, hello, we put these up to our heads every single day.
Oh, and sleep next to them and everything.
We sleep next to them. We use microwaves. There's more radiation in a banana, than your annual mammogram. So, this is me screaming to all of you women who are afraid of the radiation of a mammogram. Please, God.
But we'll fly back and forth and back and forth and back and forth to Turks and Caicos, to Miami, to Italy, to Portugal, to South Africa. We're always absorbing radiation.
Always.
And if I'm being honest,
Yes.
and this is, I don't want it to be in poor taste, but I'll say this. If you're diagnosed with breast cancer, you are going to have so much more radiation than you ever would have had having mammograms since 40. And that's the truth.
Yeah.
That's the truth. It's just like my patients who say, I don't want to be on, this or this because I don't want to get fat. I'm like, well, if you get pregnant, you're going to gain weight, or I don't want to do this because I don't want, I'm like, well, so, you have to kind of weigh it. But it was heartbreaking to me because a lot of breast cancers are so treatable now.
They are. What are some of the other screenings or lifestyle factors that factor into preventing or catching breast cancer early?
Yeah, for one, mammograms, obviously.
Yeah.
Self-breast awareness. So, touch your breasts. Feel your breasts. Do you know what they feel like? Do you know what they look like? Look in the mirror. Is there redness? Are there skin changes? Do you have nipple discharge? Any type of bruising and you don't remember any hanky-panky or, adult business. Any abnormalities or changes with your breast could mean that you have some type of breast condition. It doesn't mean that it's necessarily breast cancer. There are other tumors that are benign like cysts and fibroadenomas, but it's important to see your healthcare provider. And if they tell you you're fine and they don't order you a mammogram, you ask for a mammogram. The lunch lady, you're asking for more food and she's like, oh no, baby, I can't give you more. But it's it's not your food. Give me more. Why not? Why is the doctor not give you a mammogram referral? I will never understand keeping diagnostics from patients. It's an order. Give them the referral.
And here's the other thing. If you ask your healthcare provider to provide you a certain type of care and they refuse.
Ask them to document it.
Exactly. You ask them to notate the refusal and why they refused. Because you don't want to be in the position where you're trying to recollect information that is medical jargon, so you're not really going to understand it. And also why they said no, or trying to prove that somebody said no, because then they can go back and say, I didn't tell you, I didn't say no.
Absolutely. And that's just, again, this is the thread of advocating for yourself.
Exactly, that's part of advocacy.
Getting mammograms, understanding what your breasts look like, Also, genetic testing. So, and a lot of people don't know about this.
Because breast cancer, it shows up differently or later, in Black women than, and they're unaware of that.
Absolutely. Absolutely. For Black women are more likely to die from breast cancer than any of our counterparts, which means it's more aggressive or it's caught later, et cetera. But if you have a family history of breast cancer, uterine, ovarian, colon, pancreatic, stomach, melanoma, those are hereditary cancers. You can qualify for genetic testing, and genetic testing is so affordable now.
Yeah.
So getting genetic testing can mean that you find out, do I have a gene mutation or a change in my body right now that's putting me at a higher risk of having breast cancer? And if you have that gene mutation, you can get more surveillance, you can qualify for risk-reducing surgery, you basically can choose how your health goes. You can choose when you want to have kids, if you want to have kids. Do I have a high risk for ovarian cancer? Oh, I do? You know what? I'm going to freeze my eggs. You can make decisions for your body how you want to when you have that information. So genetic testing's one, and then just lifestyle stuff. So staying healthy, stopping smoking, decreasing your alcohol intake, watching your risk factors for diabetes, heart disease, et cetera. I mean, this is all the stuff that we know, but it's like sometimes you just need to hear it again.
Yeah, and exactly, and be reminded of it. So let's go on to our favorite subject, menopause and perimenopause. I love talking about this. So recently I heard menopause, just the overarching theme of menopause, because there's premenopause, peri, and postmenopause, and we'll get into that in a second. But it was described as a full castration event. It's one that men never come close to experiencing. Describe the difference between pre, peri, and postmenopause.
Okay, so when you are in your premenopausal is when you're in your 20s, 30s, just way before peri, way before menopause. Perimenopause is marked by just varying levels of hormonal changes in your body.
That's a really, really benign way of saying it.
Oh, I'm gonna take you on the ride though.
Yeah. It's basically going from 0 to 100. It's almost like being in a car that literally has an overflow of gas, and then you're driving along, and then all of a sudden it runs out of gas, and you're like, wait, hold on, what?
What happened?
Yeah.
With the decline of estrogen in the body, you realize how important estrogen is, and all the sex hormones. But we're gonna talk about estrogen for a minute.
Yes.
So as those levels decline and just go on a roller coaster, it takes you on a roller coaster. I'm talking hot flashes, hair loss, skin changes, libido goes down. That's your sex drive, right?
I'm
your
there right
skin
now.
changes.
Yeah, I'm dead from the neck down, girl. Yeah.
Your skin changes. All types of things. The architecture of the vagina can change, which people don't know about.
Oh yeah, it's called. I'm sorry, hold on.
Atrophy?
No. I got the right one. It's called urogenital atrophy, because apparently just vaginal atrophy is an outdated term. And urogenital atrophy refers to the thinning or loss of tissue, but also addresses the changes in urinary and bladder functioning, as well as other organs like the vulva and vagina.
That's right.
Basically, it means an increase in UTIs and bad bacteria, because it also affects your microbiome.
Your pH.
Exactly. And also, if you don't use it, you lose it. Yeah. So
perimenopause, usually, for all intents and purposes, we're saying late 30s through your 40s, right? You can be in perimenopause for 10 full years before you ever have that last period. Meaning this can go on for a decade. And I'm talking sleep dysfunction, insomnia, brain fog, memory loss, anxiety, depression, anger, paranoia. I have some patients who have they are meaner than a junkyard dog. I say, honey, I'm not the op. We're friends. and they're like, I'm so sorry, Monica. I'm just so hot. And I'm like, I get it. I get it. You're hot. So perimenopause can go through your 40s into your 50s. The definition of menopause is 1 year with no period. So technically, I always think of it as 1 day. So once you get to that 1 day where you've gone 1 year without a period, menopause. And after that, you're postmenopausal.
Yeah, but then you could be 55 years old and here
100%.
comes a ghost period, and then doesn't that bring you right back to square one?
So if you have 1 year of no bleeding and you ever bleed again, that is considered abnormal. So we would want to do a pelvic ultrasound, make sure you don't have any precancer in the uterus, make sure that there's no other, architectural issues in the uterus. Maybe there's a fibroid, cyst, polyps, like something else. But if you go a year with no bleeding, naturally, not because of birth control, but a year of no bleeding, and then you bleed again, that's considered abnormal. And I have patients who come in there in their 60s, like, you know what, I've been having periods. I'm like, I'm sorry, come again? You've been what? They're like, I've been having periods. I had to buy pads. I'm like,
No, that's not normal.
no. We need to get you for ultrasound like now and get you for a biopsy. So that's perimenopause, menopause. But the fact of the matter is it all sucks. I mean, honestly, perimenopause can be more disturbing than menopause itself.
It is.
And also, we don't get taught about this. Like, you take driving lessons to learn how to drive. You do sex ed in school when you're going through that transition. You take prenatal classes to become a parent and go through that transition. There's all these transitions. But this one, no one talks about when half of the people in the country are going to go through it.
More than half.
Like,
Yeah. And what's most disturbing is just how the symptoms are basically just, they're a precursor to much more serious issues.
Absolutely.
I mean, what happens as you hit perimenopause is your bone density starts to become compromised.
That's right. Because of lack of estrogen.
Because of a lack of estrogen. Estrogen is responsible for so much of our functioning. So, of course, this conversation is graduating over to HRT, which is hormone replacement therapy. But I just need women to understand. I just had my bone density scan done. Usually they say the age of 50, but I'm 48 and I went and got mine done. So I could create a baseline.
48 where?
Thank you, girl. But guess what it said? It showed signs of osteopenia. Yeah.
Decreased bone density already.
Yeah, exactly.
And the thing is, most people wouldn't even know about that.
No, they wouldn't.
Estrogen is also like a potent indicator of fat distribution. So what happens is when you're going into perimenopause, you notice a lot of belly fat, stubborn fat that just won't go.
Yeah.
Again, lack of estrogen, loss of estrogen.
Yeah. Let me read this. On July 8th, 2002, let me preface this by saying, before I say this, there is so much fear-mongering when it comes to hormone replacement therapy.
Yeah.
There is still black box warnings on hormone replacement therapy packaging, which is so frustrating. There's a whole generation of health practitioners that do not know how to administer hormone replacement therapy to their patients because of what I'm about to tell you. In the 1960s is when doctors started to prescribe hormone replacement therapy, estrogen replacement to their patients. It took them a little time to realize that you can't just give estrogen to patients. You had to give progesterone, otherwise you ran the risk of endometrial cancer, correct?
That's right.
And so for decades, all the way 60s, 70s, 80s, up until 1992, doctors were prescribing hormone replacement therapy and women were faring just fine, with this hormone replacement therapy. On July 8th, 2002, the National Institutes of Health issued a press release, which is crazy because at that time, who was doing press releases over this study that was done? It stopped the world in its tracks as it related to menopause treatments. The National Heart, Lung, and Blood Institute of the NIH has stopped early the Women's Health Initiative, a major clinical trial of the risks and benefits of combined estrogen and progesterone in healthy menopausal women due to an increased risk of breast cancer. The Journal of American Medical Association, in advance of publishing this paper, added in its own release that the WHI study was stopped not only because of increased breast cancer risk, but also because of increased risks of coronary heart disease, stroke, and pulmonary embolisms. They misinterpreted the data so drastically that you had a whole generation of women with crumbling bones, with literally with developing osteoporosis, developing early onset Alzheimer's and dementia, developing all of these issues, heart-related issues, bladder-related, all of these medical issues that could have been helped by having hormone replacement therapy. It's only now being discussed in conversations like this because I refuse to let women believe that this debunked study and medical study, or whatever the case is called, still holds true today. So you prescribe or deal with patients and HRT.
I do.
Okay, talk about that.
I do every day.
And how much of an education you have to give them.
A lot. I do. But I will say this. Honestly, right now, podcasts and shows and talks and social media like this is actually getting women to come to me, feeling empowered. And they're actually like, I want HRT. They're not scared anymore. They're like, I want HRT. You know, the study, I think what's missing is that we see an increased risk for breast cancer after 5 years of use, but it's still very small.
Yeah.
So it's misrepresented.
Yeah.
I think 8 additional cases per 10,000 women. Again, and there could be other factors there. So, you know, no study's perfect. So there could be other factors there. But we see that after 5 years of use. Sometimes my patients just need a few years to get over the hump. And I have some patients who are in 70s and they are holding on to their HRT and they're like, I want my refill. And I'm like, okay, period. I'm gonna give you your refill. We know now that it is safe to stay on HRT indefinitely. It is. It is safe. So I feel very comfortable with my patients. Now, you know, if the patient has a history of a liver disease, a gallbladder disease, if they have a history of breast cancer themselves, this might be a different discussion. If they have a history of a clotting disorder or blood clots in their legs, but otherwise, for the most part, it's very safe. And when I say it is life-changing, I have had patients get their spouse back, their friends back, their job back, because they done kicked everyone to the curb from their perimenopause.
Trust me.
It's life-changing. So I prescribe HRT. I feel very comfortable prescribing HRT. I think there's a knowledge gap. It's not taught in schools how it should be.
Medical schools, yes.
And I mean, and I've had medical students say like, oh my gosh, where did you learn so much about HRT? And I'm like, honestly, I learned it on my own. I go to conferences all the time. I read the American College of Gynecologists Green Journal, just reading up, I mean, learning, you know, and then practice. I've been doing this for, you know, over a decade. But I feel very comfortable prescribing HRT. It's life-changing. And the thing is, you can see what's good for you. So some patients, they might just have a little bit of vaginal issues. You might just need a little bit of topical vaginal estrogen, which is a little vaginal estrogen that can help to prevent UTIs.
I have a statistic to tell you.
Tell me the statistic.
Okay, so the statistic that I heard is that if everyone in the Medicare system prescribed vaginal estrogen, it would save Medicare $6 to $22 billion. I don't think that y'all are prepared for what happens during perimenopause and menopause, what happens to your vag, okay? It goes through such a drastic change that you just are not prepared for. And through conversation with my gynecologist, I was like, prescribe me vaginal estrogen, because it literally kind of like, it brings it back to life. It brings it back.
It's rejuvenating. I mean, the thing is, we put moisture on our skin.
It's the same.
You would never go your whole life
thing
without putting lotion on your face.
Yeah.
Or moisture on your skin, right?
Yeah.
So the vagina needs moisture too.
It does.
And the thing is, vaginal tissue is estrogen dependent.
Yes.
The urethral tissue, the tissue around the little hole where the urine comes out, estrogen dependent. So again, patients who are having recurrent UTIs, recurrent urinary issues, recurrent vaginal infections, it could be because of the decrease in estrogen. Some vaginal estrogen takes you, I mean, I have patients who are breastfeeding.
Yeah.
And when you're breastfeeding exclusively, it drops your estrogen. And I have them on vaginal estrogen because they have lactation, they have vaginal atrophy from breastfeeding. So I love vaginal estrogen.
I love it too.
And I prescribe it all the time.
I love it too.
I hope more providers feel comfortable prescribing it because it really is life-changing.
That's what I hope that this episode does. And also, when it comes to HRT, it's not just about estrogen and progesterone, it's also about testosterone. Women have such a fear of testosterone, but we have testosterone. Our bodies create testosterone. We need it. You know what it equals? Lean muscle mass. It equals, you know, joints that don't freaking ache. It equals energy. So we do need testosterone replacement along with the estrogen and progesterone. So do not fear getting testosterone prescribed to you. Really have these, you know, flushed out conversations with your healthcare provider, your PCP, your nurse, your gynecologist about this. And, you know, if you don't feel like you're getting the right information, then you have to move on to the next, because this is really life or death as far as I'm concerned.
I was going to
HRT.
say, to your point, and I love that you said that, I think it's so important to find healthcare providers who are very knowledgeable and well-versed in hormone replacement so that you don't get botched.
Yeah.
So testosterone is technically not FDA approved in the US. And for some, they're like, oh, well, I'm not going to prescribe it. That's it.
Yeah.
And for some, they're like, I don't really know how to prescribe it. I guess I'll give you this. And for others, they're like, okay, we're going to do a little microdose because you're having low libido, because you're having sexual dysfunction. It's called hyposexual, dysfunction disorder. We're going to give you this because this is going to help. They give you a little testosterone gel, put on your little calf or wherever. It's just transdermal on your skin, and it can help. So, I think that, again, education, finding a provider that knows what they're talking about, and it's okay. I mean, if you find someone and they're just like, I don't feel comfortable, thank you.
Yeah.
And I'm going to move on.
Yeah.
And find someone who feels comfortable to meet all of your needs.
I want to get your final thoughts on something before we leave. And also, I'm coming down to Maryland to your practice, okay? We're going to shoot some content at Monica's practice because
oh my gosh, come.
I did not get enough time with you today.
I don't feel like we did either.
We did not have nearly enough time. I really wanted to have some, like, mimosas here for you and stuff like that, but it is like the air conditioning broke in here, girl. It's hot. But final thoughts before I let you go. What is one thing that you wish every woman listening to this podcast knew about their body and health? One thing.
Your body is not against you. Like, it is what it is. And knowing more about your body and understanding your body and what's normal for you and what's abnormal for you will help you to be able to just advocate for yourself so that you can live your best life possible. We should feel good in our bodies. And there are so many treatments that can help you feel good in your body. And it doesn't mean you have to be on hormones. It doesn't mean you have to take medications. When I say there are so many treatment options, there are so many treatment options. But I think the first thing is people just knowing, like, okay, my period lasts for 14 days. That can't be normal. It's not normal. Yeah. I'm hot and I can't sleep at night. That can't be normal. It's not normal. It is normal. It's common, but it doesn't have to be your story. Yeah. So I think really understanding your body and knowing when enough is enough and saying, you know what, I want to feel good again. I want to feel like myself and I don't feel like myself. Take the time to seek out a great provider who's going to work with you to help you feel like yourself so that you can live your best life and be fully functioning again. Because we need women. We need us in a good place. How would it be if all of us are just mean, right? It would be angry, hot.
I'm thinking about what it
dry.
What it would be like if we were all happy.
Right?
The world would be a beautiful place.
We deserve to be happy. And I think one way to be happy is first just to feel good in your body. And to feel good in your body, you gotta go and get your health care. Like, get your care.
Nurse Monica Carter, tell them where you can be found.
Oh, you can find me on all social media platforms at Monica the NP, Monica the NP as a nurse practitioner. If you are looking for a healthcare provider, come to Washington, D.C. I'm over at Georgetown. Come see me. We are always accepting new patients. And then hopefully you'll see me back here with Melyssa because we have more to talk about.
You are definitely going to be back here, or I'm going to be at your practice. We're going to put all of your information in the show notes in the show episode. I cannot thank you so much, enough for coming to, hang out with me and educate the audience on things that they really need to know about. This is a subject I'm so passionate about, you're so passionate about, and there's just so much more information that has yet to be uncovered because, by and large, we are ignored by the medical industry.
Oh, 100%.
Yeah, don't get me. That's another tangent. I'll go off on.
I was going to go off too, and I will say this, and this is my best advice all the time. When you go to your healthcare provider's visit, come on time. Know your medical history, your surgical history, your family history. Have your questions ready. Come on time. Because the thing is, you want to make sure you maximize the time you have with your healthcare provider. And don't try to fit everything in one day. Yeah. Go if you are having menopausal issues, just make a visit just for menopause. Yeah. Just for menopause. And then that makes it so that they have to address it that day.
That is really good advice. I want to thank you all for tuning into another episode of Hot and Bothered with Melyssa Ford. And if you could be so kind as to like and subscribe, hit the notification bell, wherever that is. It's over my shoulder somewhere, but hit that so you know when a new episode drops. But until then, take care. Thank you for tuning into Hot and Bothered with Melyssa Ford. Please rate, subscribe, and comment, and share wherever you get your favorite podcasts. This season of Hot and Bothered with Melyssa Ford is hosted, written, and executive produced by me for Forged Path Productions. This episode was written and produced by Sebastian Godin. Filming and editing of this episode is done by GVI Films and executive produced by Rachel DeSalvo.